Evening, everyone.
Oh, my CR. Good evening,
Oh, yes.
Dr. Charu.
Good evening, Bala.
So it's a pleasure to have Dr. Charu because she taught me anesthesia.
Oh,
The baby steps. The baby steps.
Yeah, baby steps.
And
Yes.
also she remains as young as what I saw her decades ago.
Oh.
He is a moderator for the session, sir.
Oh,
Dr.
that's
Charu,
lovely.
madam.
Yeah, very nice. Yeah.
Madam, we need to take the questions immediately after Bala sir's lecture because
Okay.
you want to leave.
Okay, yeah.
So, request all audience to put questions in the chat box.
But if they
Good
have
evening,
any,
Charulata madam.
if they have
Good evening, good evening.
any other
Good evening,
questions,
Nita.
my colleague Dr. Sendil will answer. So
Yes.
in case if yeah.
Sir, good evening.
Good evening very much, Dr. Vikas. I think every association depends on the treasurer of how well the association runs.
Balaji sir, good evening. Rajesh sir.
Good evening.
Gadkari madam, good evening.
Good evening.
Parna madam, good evening. Shilpa madam, good evening.
Good evening.
Good evening. Good evening.
Avinash sir join झाले.
Good evening, everybody.
Good evening, Avinash.
माझा व्हिडिओ का दिसत नाही.
सर सिझेरियन चालू आहे.
नाही आज नाही. आपण संपून आलो.
Sir is always busy.
Avinash sir is always busy.
Yes, Avinash sir is always.
माझा व्हिडिओ दिसत नाहीये.
Video on करा sir.
केलाय पण ते काय होत नाही का चूज व्हर्च्युअल बॅकग्राऊंड चूज.
आमच्याकडून काही प्रॉब्लेम नाहीये.
नाही तुमच्याकडनं नाही माहिती आहे ते सगळे दिसतायत ना.
Parna madam and Vikas sir, we miss you at the GC meeting.
Yes, ma'am. I missed it too. I was traveling on
Yeah.
that day itself. My travel
Yeah.
started that day itself.
Even we missed it, ma'am.
Rajesh, should we start? 6:31.
Yes, we will start now. Very good evening. Very good evening to all respected ISA members of SAMS and who all have joined this webinar, today's webinar. Today we are privileged to have great faculty. Our President-elect of National ISA and Secretary of WSSA are available as a guest speaker. And Dr. Senthil Kumar is another lecturer from Ganga Hospital. And this is fifth webinar of our webinar series on recent advances. Today we are dealing with the regional anesthesia. And I would like to request Dr. Balaji Asagaonkar, our President of SAMS, to brief on this webinar series.
Welcome to the online academic platform of Society of Anesthesiologists Maharashtra chapter. During our tenure, we initiated the recent advances series, which has been highly appreciated by all of you. Today, we are honored to have Dr. Bala Venkat, a stalwart in regional anesthesia, with us, and he is going to talk about recent updates in regional anesthesia. I personally thank him for accepting our invitation. I also extend my gratitude to Dr. Senthil Kumar for presenting his talk on this platform. So without wasting much of time, I request to begin the session. Thank you very much.
First of all, I would like to welcome Dr. Charuta Gadkari Madam, our ex-Vice President of SAMS, and request to Dr. Vikas Karne to introduce our moderator, Dr. Charuta Gadkari Madam.
Thank you, Dr. Rajesh, and good evening to all. And thank you all for joining today for this webinar on recent advances in regional anesthesia, which is organized by SAMS. We are excited to have with us Dr. Charuta Gadkari Madam, Today's topic is regional anesthesia, and it is now becoming a cornerstone of contemporary anesthesia practice, and it's offering significant advantage for our patient care and also helping in a great surgical outcomes. Today's webinar will provide valuable insights and practical tips to all of us. I'm delighted to introduce our moderator for today's webinar, Dr. Charuta Gadkari Madam. Madam is an alumnus of BJ Medical College, Pune, and currently serving as a professor in emergency medicine at JNMC Wardha. She has 30 years of experience as a teacher, over 30 years of experience as a teacher in anesthesia, and she brings a wealth of knowledge and expertise to our discussion today. She has been vice president of Maharashtra State ISF and also have served 2 terms as editor of MISA News. Madam was organizing chairman of first ISA Maharashtra Biennial CME at Nagpur in 2013. She has also served as secretary and president of Nagpur City ISA branch. Gadkari Madam has many awards to her name, including President Appreciation Award by MSc ISA, Prestige Nursing Home Award, Srimati Sushila Bai Sathe Memorial Award, just to mention few. Madam has been invited as speaker at both national and state level, and she has published many publications in index journals. She is a PG guide and examiner, not only for anesthesia, but also for emergency medicine now. Madam, we are blessed to have you today as a moderator of this session, and we look forward to your expert remarks and inputs. Please join me to welcome Dr. Charuta Gadkari, Madam. Over to you, Dr. Rajesh.
Thank you, Vikas.
Thank
Welcome.
you, Vikas. It is my privilege to introduce Dr. Bala Venkat sir, who is the first speaker of today's webinar. Dr. J. Bala Venkat Subramaniam sir, he is a senior consultant anesthesiologist and academic director of Department of Anesthesia and Perioperative Care, Ganga Medical Center and Hospital, Coimbatore. He is also secretary of World Federation of Society of Anesthesiologists, that is WFSA. He is our national president-elect of ISA. He is the academic chairman of Asian Ocean Society of Regional Anesthesia and Pain Medicine. He is national chairman and academic of Regional Anesthesia of India Education Committee member, WFSA. I would like to request Dr. Bala Venkat sir to start his lecture.
I consider it a great privilege to be a part of the webinar series organized by the Society of Anesthesiologists Maharashtra State Chapter, one of the most vibrant chapters in this country, with a lot of productive work and impactful work for the fraternity of anesthesia. Respected President Dr. Balaji Singonkar, Secretary Dr. Rajesh Tegdapalli, Vice President Dr. Avinash Bosle, President-elect Dr. Anita Nete, she said she is not available today, Treasurer Dr. Vikas Karne, and the news editor Dr. Parna Taka, and the moderator of this session and my chief resident when I was doing my postgraduate, Dr. Charuta Gadkari, and all the senior members of the profession and dear friends. I thank you for the opportunity, and I look forward for interactive session on a topic which is extremely relevant to the current anesthesia practice. My topic is regional anesthesia and analgesia, an update. I decided to keep it very clinical. I decided to keep it in a way to question ourselves, to introspect, and to see where we are and how we can move forward in offering this service to our clinical surgical patients. I bring to you greetings from the city of Coimbatore, which is symbolized by the Isha Yoga Center and Adi Yogi. It's has become a kind of a monument for this country, and few thousand visitors visit this center every day. And the laser show, which brings into us how yoga evolved in this world, is an absolute treat to the eyes. So those who haven't seen it should come and see it. And I take this opportunity also to welcome you to the Ganga Anesthesia Refresher course. We will start our registration soon, and it's going to be on the 30th January to the 2nd February 2025. And we always go for a breakout session to this center to imbibe the power and the virtues of a holistic growth. All my presentations have 2 slides for several years now, and I make it a part of every meeting, which should call for introspection for each of us. So it says that we may be born in a middle-class family, but we can scale such heights in this lifetime that we can cause a revolution. We may be born to illiterate parents, but we can die as a scholar of world repute. We may have been considered a misfit during our childhood days, but we can become role models for the future generation. What we are and what we have been has no bearing on what we can be. We can be what we choose to be. But if we want to accomplish this, it becomes very, very important. We need to keep asking ourselves and tell ourselves that our future comes from where our time goes. So where should our time go? For everything that you want to do, you need to have the time. In essence, we reach a point in life when time almost becomes our God. I think these two are profound slides, and each word has a meaning. And it is so important that all of us who are professionals have to respect time and devise strategies on a day-to-day basis on how to utilize this time. We are not any other professional where we can lead a life without giving importance to time. Because our challenges are huge, we have to be clinically relevant. We need to be knowledgeable. We need to be skillful. And if you need to continue to grow like that, it becomes important to invest time very, very appropriately. And if that happens, then all of us will succeed in life when our core values are very strong. So success is all about being in the process of joyfully creating a life that reflects our higher values, deepest beliefs, and greatest dreams. So we should dream to make sure that the Indian Society of Anesthesiology becomes a global entity, and our morbidity and mortality in the perioperative period should be highly minimized. And we need to focus a lot on patient outcomes. And webinars like this are extremely important to guide us towards that direction. We are all fortunate to be born in this country, which is really modern, diverse, and peaceful. And recently I presented and I made the slides for my talks in Colombia. And I just wanted to tell them what we are. And if we know that we are the largest growing economy among the larger economies. So we need to be really proud of, and we have some of the best networking system today in the world in terms of highways, in terms of air transport. Considering the dimensions of our country, the way we have grown in the last decade has been phenomenal. And we are also in the forefront of artificial intelligence and robotics, and also very, very important, nowhere in the world the unified digital payment which we have now, which even a vendor has it, is nowhere in the world the intensity with which it is practiced has taken place. So we need to feel happy for several of these reasons. And also the most important component which will lead us into the next decade and why the world is looking at us is because India's working age population by 2023, which means the number of people who can work on a day-to-day basis is 1 billion people. No other country possesses this big workforce of 1 billion people. So this is to put it in the perspective that we are very fortunate to live in this country. Extremely modern we have become, and we had the landing in the moon, and our ISRO is doing excellent work in sending space satellites. The modern software industry and the modern downtowns look like any other country in the world. I bring to you greetings from Ganga Medical Center and Hospital, Coimbatore, and I bring greetings on behalf of all the departments of our hospital, and it's only 3: orthopedics, plastic surgery, and anesthesia. As you all know, that in the last, since 2002, we have weaned off all the other departments, and anesthesiologists in our institution serve as perioperative physicians. And I also would wanted to thank all my teachers, and especially when it comes to the state of Maharashtra, I had my baby steps in anesthesia there. So that's the BJ Medical College, Pune. And again, I would like to thank all my teachers in BJ Medical College, Pune, including Dr. Charuta, for guiding me to be what I am today. What are the updates of regional anesthesia and analgesia? This name of regional anesthesia was coined almost a century ago by Harvey Cushing. And this is a very appropriate statement. Everyone who is using regional anesthesia, especially if they're using a nerve block, they wanted it to work, because the surgeon brands you as a good regional anesthetist if he sees giving you a block to the brachial plexus, and if the block works without supplementing any other form of sedation. That is called the purest and the highest form of regional anesthesia and analgesia. So Dr. Moran mentioned regional anesthesia always works provided you put the right dose of right drug in the right place. I would like to add, for the right kind of surgery, because many times you think that you have given the right block, but we have failed to discuss with the surgeon what incision is going to make and what are the possible nerves that supply that region, which does not take part in the block that you gave. For example, if you want to do a proximal humerus fracture, and if I ask a question, I think all of us would say that I would give an interscalene approach to brachial plexus. So we placed the drug either with the use of a peripheral nerve stimulator or with the help of an ultrasound, or even you did a dual technique because the patient was a very important person. So you use the ultrasound to see the brachial plexus, and you used a peripheral nerve stimulator to stimulate, and you injected the drug, and the drug spread was excellent. And according to you, you have performed the block extremely well. And now you will ask the surgeon to go ahead and do the surgery after 15 minutes of the soaking time of the local anesthetic on the neural tissues. But when the surgeon makes an incision, patient shouts, and he considers that it is a failed block. Though the patient was not able to move the limb, but still he shouted. So where is the fallacy? The fallacy is we gave the block perfectly well, but we failed to take into account the dermatomal supply of a proximal humerus fracture. Is an incision is made right from near the axillary fold, and the dermatomal supply, a few twigs come from the superficial cervical plexus and the intercostobrachial. Both of them have not been blocked by us, and this results in a kind of a failed block. So it becomes important. It's just not the right dose. It's not the right drug. It's also not the right place because you gave it in the brachial plexus, but to take into consideration the myotome, the dermatome, and the osteotome. So it's like mathematics. So you need to discuss with the surgeon, what is the surgery? What is the approach? Then you will have to calculate. So C5 to C8 dermatome is involved. C6 to T2 myotome is involved. And C8 to T4 osteotome is involved. Like you are trying to kind of make it as a mathematical calculation. And you need to assess the block that you give, whether it will take care of all this dermatomal, myotomal, and osteotomal supply to declare that you have given the right kind of block. At this juncture, I would like to really bring into submission, the work played by the Academy of Regional Anesthesia of India, which was started way back in 2011 in Maharashtra, in Mumbai, which has tried to evolve and teach people across the country by conducting innumerable number of workshops and an annual conference. The upcoming annual conference is going to be in Hyderabad in the month of August, 3rd week. So I would take this opportunity as a member of the Academy of Regional Anesthesia of India, would request as many of you as possible to participate in this conference, because it's a big learning. Regional anesthesia is evolving on every single day with new blocks, new drugs, new approaches, new understanding. So it's important to evolve as a good regional anesthetist. And this is extremely important for advancing the quality of patient care. And I just wanted to quote that one of the things which we have really accomplished in this country, this picture was taken long ago when we were using only a landmark technique, but the concept of on-arrival block was brought in. So the same thing we do now, but of course with the help of ultrasound. But the point that I wanted to drive home is one of the best thing that each one of us can do if it's going to be an update on regional anesthesia is to see how much we keep our pain free, especially when they come with a trauma to the institution where we are working as an anesthesiologist. Can we do something to make them pain free on arrival? I think this introspection, I would wanted all of you who are attending this session to ask yourself the question, is this possible in your institution? If it's already happening, then I think it's excellent. But if it's not happening, I would like to ask each one of you to introspect, ask a question yourself, find out how this can be done and how to evolve a strategy and a system to make sure that a patient who is writhing in pain with an injury like this, imagine the amount of pain that he would get. When we are using a knife, a small cut if we have, you can know how much nociceptors get stimulated and how painful it is. And for an injury like this, it's going to be phenomenal. Since we have the know-how, since now most of the hospital has got either a peripheral nerve stimulator or ultrasound, I think it is prudent and important that immediately on arrival to the hospital, we need to make them pain-free. This is the first take-home message. And each webinar, if it has to make a difference in the practice of each one of us, it happens only when we question ourselves from what we learn in the webinar. And so this is the first take-home message I wanted to give. And you need to take it in a very big way. There will be a lot of hurdles from the hospital administration, from the surgeons, from the anesthesia department, from the availability of the machine, from the availability of the machine, not in the daytime, but in the nighttime also. But I think each challenge has a solution, and we need to move towards taking it up in a very, very big way, because it will make a huge difference for the patient who suffers such mangled extremities, and your presence should make the difference. This is just by owning more responsibility and also enhancing the reliability. If we do that, like what Jim Collins said, we move from good to great. And this would be excellent. And if this has to happen, and one of the biggest impediment for development of regional anesthesia in the world has been the non-availability of a block room. So I would urge the second take-home message of an update on regional anesthesia is the strategies. First one is on-arrival block. The second one is there a block room in the hospital? Or should the patient be blocked only inside the operating room? Many surgeons do not allow a block to be performed inside the operating room because every minute inside the operating room is charged. And the first hour in the operation theater cost in the first hour is more than the second hour, and they don't want to lose it for anesthesia. And hence, they say that it's okay, give off general anesthesia, give it off general anesthesia. And if you see the world statistics today on the number of surgeries based on the current data available, in a superb editorial written by Dr. Christopher Louis, who is from the Hospital for Special Surgery in Manhattan, New York. In this edition, of regional anesthesia and pain medicine, he was awarded the Gaston Lebot Award, one of the highest award for a regional anesthesiologist of the American Society of Regional Anesthesia and Pain Medicine. In that, he has written, based on the data available, every year, 300 million surgeries take place across the globe. And he adds, yet another 143 million surgeries had to be performed, but the low resource countries did not have the surgeon or anesthetist to perform, resulting in surgery being not performed. This is another very big message that we need to take home, and we need to assess this. So on an average, 300 million people undergo surgery, and the morbidity and mortality happening even today is 1 to 4%, and majority of them is in lower income countries. So it goes on to say 8 million people had severe morbidity or mortality because of perioperative care, including anesthesia practices in the world, even today, after we have developed so much and after we have evolved so much. And it says that the current literature also indicates in low resource setting, if neuraxial block or a peripheral nerve block is given, the morbidity and mortality can come down by close to 80%. And the more morbidity and mortality happens when the patient is subjected to general anesthesia and the possible problems that they have, including oxygen source and postoperative care and the monitoring in the postoperative care. So why I wanted to emphasize this point is, it is becoming clearer that all the centers which practice regional anesthesia as a tool can bring down the morbidity and mortality to a great extent. And for promotion of regional anesthesia, it is very vital to evolve strategies. And this is a block room. I would request all of you to consider starting a block room or creating a space in your operating theater complex, which could be used as a block room, which just has the adequate infrastructure, including the machine, either a PNS or an ultrasound, a multi-parameter monitor, a source for oxygen, and an emergency cart. And I think with this, it will be great to start a block room. And throughout the world, all the centers which has emerged as a very big regional anesthesia center, providing opportunity for evolution of regional anesthesia, or hospitals which have a block room. And as I said, the ultimate aim is for block success. There's an excellent article, and I just would wanted all of you to go through. It's available in Google, the definition of block success in contemporary literature. But as I told, a successful block is one which takes care of all the three components, the dermatome, myotome, and osteotome for a particular surgical procedure. And to be successful, we need to know the anatomy, in the internal milieu and the physiology of the patient, and the drug that you use, the pharmacology of the patient. Rapid strides have been made in the outcomes in regional anesthesia of late. It's because of the availability of a tool, ultrasound and a peripheral nerve stimulator, and a great learning about the anatomy, both descriptive and the topographical thing, which is evolving, and a lot of cadaveric studies have completely revolutionized our understanding of regional anesthesia. And the technical skill and experience and expertise has also been on the rise, and also, as I mentioned, appropriate block for appropriate surgery. If it is all done, the anxiety that the anesthesiologist undergo and the hurried way in a block is performed, which are the two important causes of block failure, can be obviated. I think it's another big take-home message. So this is the nerve that we need to block when we use a nerve block technique, either with PNS or ultrasound. So this is an important slide which I wanted to share. There are 4 coverings, like you see, this is the paraneurium, and you will see the epineurium and you can see the epineurium, the perineurium, and the endoneurium. So when you inject a drug, when you inject the local anesthetic solution, it is called extrafascicular, and also subparaneural. This is called the sweet spot of the nerve. Very safe and very effective. So the subparaneural injection is called the new highway of depositing the drug. But when we use a PNS, there is no way to find out where you place the drug, whether it is subparaneural or it became subepinural. This is on the right side, you see the classification. So two of the predominant place in which the drug is deposited is just below the paraneurium or just below the epineurium. And point why we should know this is whether the rate of onset of the block will be reasonably good. But suppose if you are called on to say that the block lasted for a long time, it's 12 hours over, 16 hours over, still the block has not resolved. So this is when the question comes, and here we need to know, when you do a subparaneural deposition of the drug is taken away by the blood supply, the venous supply which comes in, and it is moved faster. So the amount of molecule that are available at the site becomes less, and the patient recovers from the block. But when it becomes subepinural, the point is, compared to the subparaneural, the rate of absorption of the drug by the venous system is less. And so the drug molecule are available at the site for a longer time, and the duration of the block is going to be prolonged. This is a take-home message. So majority of the times when the block is prolonged, it is primarily not because of a neural injury. It is because of deposition of your drug in the subepinural space. This is something which I wanted all of you to consider. And current literature wise, the injury happening because of the block itself is on the decrease now. And thanks to the advent of ultrasound, it's become further less. And when you use an ultrasound for getting an optimum block, it is said to get a donut sign, but this has also been questioned. And however, if you achieve this, you're considered an excellent ultrasound guided regional expert. Yet another thing that we need to know is when you deposit the drug around the nerve, so it goes from the periphery, the mantle fibers, towards the center, the core fibers. So after giving a brachial block, when you want to do the test, the first thing happens is the loss of the proximal muscles and the
Can't hear.
Sir, you went on silent.
Yeah, you can't hear me
Yeah.
now?
Now we can hear you.
Yeah,
No.
okay. Yeah, so is it okay?
Yes, sir.
Yeah, okay. So when we give a block, we need to understand that the block comes from the proximal to the distal. And so when we assess a block, based on the timing you gave the block, it should be the proximal component first or rather than the distal part. Because I've seen many people give the block, for example, subclavian perivascular approach to brachial plexus, and after 10 minutes, they will ask them to move the fingers, which many patients will be able to do because the core fibers have not been soaked and the core fibers have not been blocked. So this is another take-home message that I thought I should give. Why is regional anesthesia and analgesia has become so important component of the perioperative care? Even if we do a case under general anesthesia, now there is a strong recommendation to use regional analgesia as a component of multimodal analgesia. And one example is what we do, for example, in our spine surgeries. So we use erector spinae block. And to be very specific, if we have an idiopathic scoliosis now with roughly about 6 to 7 segment of spinal segments involved, a big tissue injury happens, and compared to the earlier days when we were not using erector spinae and the case was done only under general anesthetic versus now doing the same case under general anesthesia with incorporated 4-quadrant erector spinae block, we see a huge difference in the immediate outcome. Number one, the total amount of anesthetic agent required to produce the same amount of bispectral index. So we keep the BIS around 40 to 60. The total volume of our anesthetic agent, now we have actually moved from inhalational to total intravenous anesthesia target controlled infusion. So we are finding that the total amount of anesthetic agents that was consumed in the intraoperative period is much less. Number two, the hemodynamic changes that happen to the surgical stress is very less. Number three, at the end of the surgery, you have a pain-free patient, and ability to extubate the patient on table is very high in spite of phenomenal amount of tissue injury. And after you extubate, you do not hear any noise from the patient because he's extremely comfortable. I think each one of us have to work towards this, that our patients whom we anesthetize, it is our expertise and it's our responsibility to keep them pain-free by all the methods that are available today. So in spite of giving a general anesthetic, it's important to use a regional technique. I think this is another take-home message that I would wanted to give. And many people questioned why two things are together. It is not overdoing. It's not actually overdoing. It is really able to making assist the patient and making him very, very comfortable. Not only for this physiological parameters, but also because of the chemical parameters. The biomedical stress response, the stress response results in release of a lot of biochemical mediators, which also enhance its effect on the nociceptors, and even the production of that. For example, the interleukins, TNF-alpha, all of the production is also less when a regional anesthetic is used along with general anesthesia. So the stress response for any trauma surgery is mainly mediated through metabolic, immunologic, inflammatory, and neuroendocrine. And regional seems to play a vital role in decreasing the inflammatory response. And not only that, it also, when you provide regional anesthesia, there is decreased in the blood that is lost due to a surgical procedure. The rheology in the microcirculation is excellent because of vasodilatation, and also for several reasons, when you use regional anesthetic technique, the deep vein thrombus formation is less, and because of ambulation, early ambulation, the incidence of deep vein thrombosis also becomes less, and also it has been found to produce improved gastrointestinal function. And now there are a lot of studies which are focusing on enhanced recovery after surgery. And many, many trials have shown that incorporating a regional anesthetic technique as a tool in enhanced recovery after surgery has resulted in better outcomes, early discharge, less postoperative nausea, vomiting, less use of opioids, less number of days in the hospital, and good organ function. So there is very strong evidence to use regional anesthesia and analgesia as a component of ERAS protocol on whichever surgery that you do. And in the next few minutes, I'll finish, but I just wanted to share with you, all of us, when it is regional anesthesia, gave a lot of importance to upper extremity block and lower extremity block. But the last decade saw a plethora of new blocks coming in, and that is because of what we call it as interfacial plane blocks. And when it comes to thorax and abdomen, it is this interfacial plane blocks which has made a huge difference. And you place the drug in the multi-layer deep fascia that you see here, the blue color. So this is where the drug is placed in interfacial plane blocks, and this is something which has made a remarkable difference in the outcome, especially in thorax and abdomen. And compared to upper limb and lower limb, it is important to provide perioperative analgesia for thorax and abdomen because of respiration. Every time a diaphragm moves, there is a movement of the injured tissue producing pain, and it becomes pertinent that we evolve and give excellent thoracic cavity and chest blocks. So several new blocks have come up, and just to name a few, the sternotomy and fracture ribs. the block that has emerged for a sternal fracture or a sternotomy incision and going inside for a surgical procedure, I think the parasternal blocks have become a gold standard now. And it is just that you place the drug between the subpectoral block between the pectoralis major and the intercostal muscle. And this is enough to produce an excellent block. The next block which has emerged is the clavipectoral fascia block. I'm just going to enumerate. I want you to, all of you, if you're doing it already, it's fine. If not, I would want it to go more and read, because this session is not sufficient enough to go into each individual block. But this is a new, the clavicle fracture can be, the surgery, whole surgery can be done with a clavipectoral fascia block, and a very simple block to do. And this is yet another new block which has come into vogue now. For any surgery that is done in the right upper quadrant or the left upper quadrant, initially we were using subcostal tap. But the problem with subcostal tap was very limited amount, like it was only T6 to T9. Whereas when you go for an intercostal, external oblique intercostal plane block, as you see here, you get a much wider coverage between T4 and T10. It's a very simple procedure where you place the drug between the external oblique and the intercostal muscle at the level of the sixth rib. And you get such an excellent, so you use a linear probe and you place the probe at the anterior axillary line in the level of the sixth rib, because external oblique insertion starts from the fifth rib onwards. So anywhere below the fifth rib, if you keep it, identify the external oblique skin, subcutaneous tissue, then you will see the external oblique muscle, then you see the intercostal muscle, and you will see a facial plane between the two, a hyperechoic structure. And all that you need to do is place the drug between the external oblique and the intercostal muscle to give such excellent pain relief for liver resection, for cholecystectomy, and anything in the upper quadrant. So the other new block which has come up now, all of us know paravertebral block, and this is called as a new block. It is called the intertransverse process block, or a PVP block by a paravertebral block by proxy. So here, what you do is you see the three muscles here: trapezius, rhomboid, and erector spinae. And this is the transverse process of the spine, and this is the rib. This is the superior costotransverse ligament. So in a paravertebral block, normally what we do is we identify the three structures. We identify this ligament, superior costotransverse ligament. We pierce the ligament and then come and deposit in the paravertebral space. The PVS, what is mentioned, is the paravertebral space, and you see the pleura down. And the end point was the pleura going down when the drug is, local anesthetic is deposited in the paravertebral space. But now, because the incidence of pneumothorax was high, and this is a new block that is described mainly for analgesia purposes without producing any complication. So you place the drug, the anatomy, that sonoanatomy you need to get is the same, but you place the drug between the two transverse process and above or anterior to the superior costotransverse ligament, or you would actually call above the superior costotransverse ligament without piercing it. So it produces an excellent quality of analgesia. So this is a new block which I wanted to share with you. There are multiple terminologies that has been given: mid-transverse process to pleura block, multiple injection costotransverse block, subtransverse process interligamentory block, costotransverse foramen block. Many names have come in. That's why regional anesthesia and analgesia are exciting. It teaches you something every day to become better. So this is exactly to the diagram. So the two transverse process, that's the erector spine. ES is the erector spinae muscle, and you deposit below the erector spinae muscle between the two transverse process above the superior costotransverse ligament, has been found to be extremely effective. So similarly, there are multiple articles. Every day there is a new block that is coming in, and new description of depositing the drug, and new cadaveric studies to show how the drug spreads. But all are moving towards the era of producing a VAS score, a visual analog score of less than 1 in all our postoperative patients. So multiple studies. So I wanted all of us to take part in learning every day, to read little more about regional anesthesia and see what kind of block you can offer to your patient. And we are moving completely to a different era. And the next decade will see a phenomenal change. To produce analgesia, so far we were using local anesthetic solution, and we are now going towards something called as neuromodulation, where a peripheral nerve stimulator is used to stimulate the nerve without injecting the local anesthetic drug. But the electrical changes that happens in the nerve produces analgesia, and this is called the neuromodulation. New equipments are coming in for neuromodulation system. I think Dr. Sanjay Sinha, who will be coming to the National Conference of Academy of Regional Anesthesia in Hyderabad, has devised a new tool. All that it does is, suppose if you're undergoing a total knee replacement. So this tool, he will set a current and he will keep it in the inguinal region and switch it on. So this will continuously keep on giving an electrical stimulate to the femoral nerve, and femoral nerve will stop sending the message of pain from the nociceptor from the knee to the spinal cord. So this is an exciting new journey into neuromodulation, and I think we will see more of this in the coming decade. This makes it very, very exciting, but we are absolutely special. We have the power to prevent death, and we have the power to prevent pain. And I think we need to embark on the journey of making every patient pain-free. And an ideal regional anesthetist should have a sound knowledge in anatomy, treat possible complications aggressively, use all the possible gadgets to achieve perfection, and when there is a block failure, to accept it and convert it into general anesthesia, rather than giving multiple sedations without protecting the airway, compromising safety of the patient. So our mission remains to explore new indication, to seek out new research, to boldly go where no person has gone before, which every anesthesiologist should do, to put the patient first. And I bring to you greetings from the Department of Anesthesia, Ganga Medical Center and Hospital, Coimbatore. And we train close to 100 anesthesiologists every year. A 6 months and 1 year program, we have about 80 fellows and 24 postgraduates, making that we touch 100 young minds every year to make sure that they embark on the journey. They just wanted to show that since 2014, we also started sharing our knowledge and expertise to colleagues from outside India through the WFSA fellowship. So we are happy to say now we have 34 trained regional anesthetists in 18 countries apart from India who got trained with us through the WFSA program. So if we need to make sure that we lead a life of perfection and holistic growth, we need to exceed our own expectations. And for that, we need the skill, the knowledge, the integrity and honesty and humility. With these four pillars will result in the evolution of excellent anesthesiologists in this nation, which will put this country forward and put India first by their contributions to every single patient, and by contributing regional anesthetic technique and analgesic technique to every single patient, and make sure the noise decibel sound in the preoperative room is similar in the postoperative room. The day we achieve it, we have got the right kind of regional anesthesia and anesthesia into clinical practice. Thank you so much for your patient hearing, and I hope I was able to convey certain take-home points regarding regional anesthesia. Thank you.
Thank you very much, Dr. Bala Venkat sir, for the excellent lecture on regional anesthesia. In day-to-day practice, we all go for regional anesthesia, but it was an excellent lecture to update and upgrade our knowledge and equipment to give regional anesthesia for patient safety and better analgesia. I would like to request Dr. Charuta Gadkari madam to give her expert opinion on this lecture, as well as to conduct the question and answer for this lecture only, because Bala Venkat sir want to go early. I would like to request Dr. Gadkari madam.
Unmute yourself. Unmute yourself.
Yeah. So congratulations, Dr. Bala. Wonderful lecture as usual. We were expecting the same and it has been the same. Now that I work in emergency medicine department, I realize how much knowledge about analgesia, knowledge and of course the attitude about analgesia is lacking in other specialties. Particularly, we are acutely aware of analgesia, the techniques and the drugs, everything. So we are really blessed that we are anesthetists and we are aware of the analgesia part and the requirement for analgesia as such. And I agree that with the advent of ultrasound, the practice of blocks or regional anesthesia has really become very safe and precise. In our institute where I was working as anesthetist earlier, we did insist, we had a fight with the management people or the administration to have a block room. And we really saved that block room because we were continuously being asked, like, can we use that as a OT? And we simply refused that we want to use it as a block room. And we have had a great use of that block room in our anesthesia practice. I was very impressed by that fact about the subparaneural and the subepidural deposition of drugs, because very often the calls do come from the surgeons telling us that the block is excessively prolonged and we are not able to sort of judge the functional aspect of our surgical patients post-operatively. So one of the reasons that you have mentioned, it has been a great explanation about it. If I would like to look at the questions which have been asked, there is one question somebody wants to know about the TCI settings when you are using it for the spine surgeries.
Okay, madam, I'll do one thing. That's a big lecture by itself because you need to use first, you need to choose the formula which you want to use. There are 16 different formulas available, and it's based on the pharmacokinetic model of 3-compartment pharmacokinetic model. And it depends upon the plasma concentration and the effect site concentration. So I request Dr. Balaji Asingonkar to have, in recent advances, one full session on target controlled infusion. But madam, if you can send me the anesthetist who had requested for this, I can send our protocol to him. The other option is to have a full webinar on TCI. Madam, you've muted yourself.
Garkadi ma'am.
Oh, but I'm not doing anything. It has suddenly become mute.
That computer problem.
Okay, then I'll open this for
No,
the.
now it's clear.
Yeah. And in the chat box there are hardly any questions, but I like to open this up for the people who are interested to ask questions. We have expert with us.
There are more compliments than the questions in the chat
I
box.
understand. I understand that. That's very natural. But he's such a knowledgeable person in this field. It's better to ask queries if you have.
Madam want to ask.
Anybody can raise hand.
Shilpa madam.
Shilpa madam.
Yeah. Dr. Balavenkat sir, yeah, a few questions. What is your take on continuous catheters for any surgery? Though we wash up and put the catheters, are they worth it? And should it be continuous catheters or bolus?
You're talking in terms of epidural or perineural catheters?
No, perineural catheters.
So actually, there are pros and cons of putting perineural catheter. Now, to be very honest, we don't practice perineural catheters. And after the advent of using dexamethasone as an additive with 4 milligram and 8 milligram, even in diabetic patients, because it does produce a small hyperglycemic surge, but it comes back to normal. So the pro and con of using dexamethasone and giving an analgesia, our audit indicates that almost 16 to 22 hours of surgical analgesia with using dexamethasone for a particular surgical procedure, and then a multimodal analgesic combination for, I think in an Indian setting, is definitely more valuable. The catheter, it has got its own issues. I'm really not worried about the infection, But catheter migration and somebody monitoring it, you should have an acute pain service department. So there are multiple factors. So the simplest solution is to go for a good adjuvant like dexamethasone.
So that dexamethasone you mentioned 4 milligram and 8 milligram. So which is advisable? 1 cc or
Actually, there are, we have seen with 4 milligram also the analgesia is adequate. But also there is no contraindication in giving 8 milligram. The reason being, it gets partly absorbed into the system. So there are few reasons why one, it prolongs the duration. Second thing is it works as an anti-inflammatory. It decreases the amount of pro-inflammatory cytokines that are released following tissue injury. Third, it helps as a good drug for nausea and vomiting. So by putting 8 milligram, there is no major contraindication, and there seems to be additional help apart from prolonging the duration.
Okay, thank you, sir. What about because of continuous spinal anesthesia and because of segmental anesthesia, do we feel that lumbar plexus block has taken a backseat, or should we still practice lumbar plexus block?
I think as far as human being live, every described technique will live. Because somebody is good in segmental spinal, somebody is good in lumbar plexus. So I think all the techniques will remain. Yeah.
Sir, hello. Hello.
Yes,
Sir,
sir.
my question is not practical, but a technical. As a ISA president-elect, there are many times the question is asked in the groups how to take a permission for USG for anesthesiologist.
Sir, yeah, I think
yes,
this has been
that is
debated.
the main.
There is the PCPNDT Act, the latest book. The latest book of PCPNDT Act clearly says even a medical graduate, not necessarily anesthetist, even a medical MBBS qualified medical graduate with a certificate in ultrasound, if it's given, he has got a possesses certificate in ultrasound, can use ultrasound. But it differs from state to state. For example, in the state of Tamil Nadu, several anesthesiologists have their own ultrasound machine in their own name. And I spoke to the joint director who gave it, who gave clearance, joint director of health. So all that they say is PCPNDT Act does not say that it has to be given only to radiologists, but it is interpreted wrongly in different states, and in different states, the act is different. Maharashtra, Gujarat, Rajasthan, they're very, very strict, but in many other states, they are not strict. So we have discussing on this several times, and I just wanted to tell you that if you go to your local. Hello.
Ganesh, can we mute everyone?
Ganesh. Yes, sir. Please continue,
Yeah.
sir.
So as per the rule, there is no contraindication. It is very important to go and speak all those who want to buy an ultrasound machine in whichever part of the country they live in. I wanted them to first, without listening to anybody, they just have to go and meet the joint director of health services of that region. Discuss with them and take it forward. You may be very successful.
Okay. Thank you, sir.
Thank you, sir. Sir, what is your take on segmental spinal and fractionated spinal? Like
actually, yeah, the good results have been initially when segmental spinal came in, a lot of people had reservations about segmental spinal. But in the World Congress of Anesthesia recently held in Singapore, there was a separate session on segmental spinal. So the world has started accepting it as an entity, and it's going to grow.
Okay, thank you, sir.
Okay, thanks.
So it's a good news for those who are already practicing. So dexamethasone and midazolam, can they be used in spinal anesthesia?
No, madam. I don't think
there was an article. Okay.
Actually, I know. I think I don't think we should go to this because I'm not comfortable with this question and using it as well. Yeah.
Okay. In one of the recent updates, it was written. And dexmedetomidine perineural, how good it is? Yeah. Initially, there were apprehension. Yes.
No, madam. Dexmedetomidine, there are enough articles, Dr. Shilpa, on dexmedetomidine as a adjuvant perineurally. But only thing is we are not sure
Right.
whether it works systemically or whether it works locally.
Okay, sir.
Dr. Neelam Nalge, we can try. You can be the first person to publish a study between Dexa alone, dexmedetomidine alone, Dexa and dexmedetomidine together, and you may get a big, like a Gaston Labort award or something.
Yes.
There's
There
no
is a one question.
contraindication. There's no contraindication.
Yeah, thank you so much, sir.
There is one question in chat box. A perfect upper extremity block in non-hypertensive patient had intraoperative hypertension in spite of sedation. Why it must have happened?
A hypertensive episode in the intraoperative period, number one, it could be the surgical pain itself, or the block was not complete, or the amount of adrenaline that was used as an additive for the local anesthetic solution, or when the tissues were touched when they were not, for example, when the periosteum is touched and when the osteotome is not completely blocked, there is a huge surge in the sympathetic response. So there are multiple reasons, and we need to analyze to root cause analysis in that particular patient.
Another question is there. Is it always necessary to do superficial cervical plexus block along with interscalene block for proximal humerus surgeries?
Yeah. So this is an important question, and you need to discuss with the surgeon because when they put the skin incision, as far as this particular proximal humerus surgery is concerned, many surgeons go to the infraclavicular region. They start their incision from there, and that infraclavicular region is supplied by supraclavicular nerves. So it depends on what extent the incision is put.
Okay, I think questions are over.
Excellent. So thank you,
Thank-
Dr. Avinash Bhosle, and I feel extremely happy and delighted to be a part of today's activity. And you're going to listen to yet another very nice talk, because anesthesia for shoulder surgeries has always been a challenge. And when we wanted yet another topic, we wanted to go for shoulder because knee and hip are discussed more and can be got away with neuraxial block. But anesthesia for shoulder is very interesting. And I'm sure that Dr. Sendil is going to bring in a lot of important components. And Dr. Sendil has been a part of us, has been our fellow, became a consultant, finished his fellowship, postdoctoral fellowship in nerve block and pain management, finished his European diploma in regional anesthesia, part 1, part 2, teaches on a day in and day out basis. So I thought he would be the best person to speak on such excellent topic on anesthesia for shoulder surgery. And I thank the entire team led by President Dr. Balaji and Dr. Rajesh and Dr. Avinash for giving me an opportunity to share my thoughts. Thank you so much.
Thank you very much, sir.
Thank you very much, sir.
So with your permission, can I take leave?
Yes, sir, please.
Yeah, thank you.
Yes.
Thank you so
Thank
much.
you.
Thank you.
Actually, sir, we are very much thankful to you for joining and delivering this excellent lecture on SAM's webinar. So thank you very much. Thank
Yeah,
you,
thank
Gadkari ma'am also.
Thank you.
Yes,
Now
madam.
we'll
I
go
want
to
to
the-
thank moderator Charuta, madam.
Yeah.
Madam, because as a CR, please give me some marks out of 10.
You have outgrown that phase now.
Thank you. Thank you so much.
Thank you so much. Thank you.
Okay, thank you. We'll go to now our second lecture.
Yes, we'll move to second lecture with Dr. B. Senthil Kumar. I would like to request Dr. Avinash Bhosle sir to introduce Senthil Kumar. Dr.
It is
Avinash?
my privilege to introduce our second speaker of this webinar, Dr. Senthil Kumar B. He is consultant anesthesiologist at Ganga Medical Center and Hospital Private Limited, Coimbatore. He has done his MBBS and MD from Tamil Nadu and done postdoctoral fellowship in nerve blocks and acute pain management and at Ganga Hospital, and also European Diploma in Regional Anesthesia. He was invited as a faculty at various workshops at Bangalore, Ganga Hospital, and Bangkok, and also Aura 23 at Pune. His areas of interest: regional anesthesia in pediatric, perioperative management of geriatric trauma, and anesthesia for spine surgeries. So, with this introduction, I request sir to deliver his lecture.
Very good evening to everyone. Thanks for the kind words, Dr. Avinash. Today I'm going to speak about regional anesthesia for shoulder surgeries. It's always very difficult to follow a big drawing. I'll try to give my best. I thank the SAMS Society and Balaji sir for giving me the opportunity. Greetings from Ganga Hospital. I have to make a disclosure before starting the lecture that my speech is going to be pertaining to the ultrasound guided blocks and not the landmark or the PNS guided, because I want to show the advantage of ultrasound guided over those things and general anesthesia. Let's brush some anatomy of the shoulder. Shoulder joint consists of mainly of two joints, acromioclavicular joint and glenohumeral joint. Only connection between your thorax and the upper limb is by your glenohumeral joint, which is little unstable, which is held in position by a group of muscles and a group of tendons. What are the indications as such for a shoulder surgery? Why we are called in? It could be either an open surgery for an arthroplasty, open rotator cuff repair, bank arch repair, Latajet repair, or proximal humerus fractures for fixation. Or of late recently, many surgeries of the shoulders are done with the help of minimally invasive arthroscopic surgeries. It could be in arthroscopic acromioplasty, rotator cuff repair, adhesiolysis, or bank arch repair. These procedures can be done under either general anesthesia, or it could be with pure regional anesthesia, or a combination of general anesthesia and a regional anesthesia. And if it is going to be a regional anesthesia, what will be your block of choice? Let's see what are the advantages of each and every one. What are the main implications of a shoulder surgery? It is the position of the patient, and secondary, it is the cerebral perfusion pressure. Let me explain to it. Most of the shoulder surgeries are done in a sitting position or semi-recumbent position, or in lateral position. If it is going to be a lateral position, it's going to be easy and it is going to be simple. But the main physiological changes occur when the patient is in sitting position. Let's see what are the physiological changes that occurs when the patient is made sit. Usually, the patient is made reclined sit up about 60 to 80 degrees, depending upon the surgeon, institution, and everything. What happens immediately when the patient is made to sit up? The blood gets pooled in your lower limb. So the venous return decreases, the cardiac output decreases. It gets worsened when the patient is done under, the procedure is done under GA. Why? Because general anesthesia, it attenuates the baroreceptor and reflexes that increases the blood pressure. One advantage with regional anesthesia is that this reflex mechanism is preserved. And once the cardiac output drops, the mean arterial pressure to the brain also drops. So 80% of the patients will have a drop in cerebral perfusion pressure, and they'll have a drop in cerebral saturation. So when you consider a map of about 70, when you tie a BP cuff in the upper limb, and when the map is about 70, but ultimately the brain is about 20 centimeters to 30 centimeters away from your heart level. So the map of the brain decreases. We have to decrease the map of the brain. For every 1 centimeter rise from the heart level, your map decreases for about 0.75 to 1.25 millimeters of mercury. This range depends upon between the young age, older age, if the patient is hypertensive, if the patient is diabetic, all these factors come into account. So you should not consider the map of the blood pressure. We have to reduce the map from the map what we see in the monitor. So there are reports and papers are shown that 80% of the patients will have a cerebral desaturation. What happens ultimately? They will have severe neurological dysfunctions postoperatively, either in a milder form like disorientation or in a most severe form of cerebrovascular accident or stroke. Even papers have shown that patients have died immediate post-op or on table. These complications can be reduced or ultimately stopped with the help of pure regional anesthesia alone. Let's see how. Regional anesthesia can be given as a pure surgical anesthesia, or it could be a perioperative analgesia when combined with a general anesthesia. Let's brush some anatomy of the shoulder region in particular. The skin and the subcutaneous tissue is supplied by the nape of the shoulder is supplied by the supraclavicular nerves, anteriorly by the axillary nerve, medially by the anteromedially by the intercostobrachial nerve, and the medial cutaneous nerve of the arm. Mostly, this dermatome is missed with our usual brachial plexus block. Myotome and osteotome is usually covered with our brachial plexus block. The myotome, most of the anterior muscles are supplied by the axillary nerve, the subscapular nerve, lateral pectoral nerve, and the musculocutaneous nerve. The osteotome, most of the osteotome, the posterior half of the shoulder joint, is supplied by a suprascapular nerve, anteriorly by the axillary nerve, subscapular nerve, long thoracic nerve, and your radial nerve. Almost 60% of the shoulder joint is supplied by your suprascapular nerve, and 40 to 50% by your axillary nerve, and rest of the nerves are minimal innervation to the shoulder. Usually, this is the typical framework of the brachial plexus. It starts from C5, C6, C7, C8, and T1. Usually, the shoulder joint is predominantly supplied by your C5 and C6. So, our main primary aim is to block these two primary ventral rami. So, this is the superior trunk. If we block the superior trunk, that's more than enough to give good analgesia for the shoulder region. Classically, ideally, the gold standard will be your interscalene block with superficial cervical plexus block. Interscalene can be done with a landmark technique or PNS guided technique. What is the main drawback of your interscalene block? It is the phrenic nerve palsy. It is an unwanted complication that can be easily prevented. It leads on to severe morbidity and at times mortality in high-risk geriatric patients with pulmonary dysfunction. What is the incidence of phrenic nerve palsy? Usually, it's about 100% when we give an interscalene block with the landmark technique or with PNS guided technique. With an invent of ultrasound and with low volume, still the incidence of phrenic nerve palsy is 20 to 40%. With the supraclavicular block, with an ultrasound guided supraclavicular block, it could be about 30 to 40%. If it is a landmark or PNS guided, it could be 50 to 60% with your supraclavicular block. Let's see how the phrenic nerve is blocked. It could be of two mechanisms, either depositing the local anesthetic directly on top of the phrenic nerve or the accessory phrenic nerve, which travel over the anterior scalene muscle, or large volume of local anesthetic ascending proximally to the nerve roots of the phrenic nerve. These two are the major mechanisms by which the phrenic nerve is blocked. The duration of phrenic nerve palsy depends upon your volume and the dose of your local anesthetic. Let's see some anatomy of the phrenic nerve. Phrenic nerve originates primarily from the C4, but it also receives contribution from the C3 and C5. Phrenic nerve lies deep to the prevertebral fascia over the anterior scalene muscle. It descends obliquely from lateral to medial border of the anterior scalene muscle. Phrenic nerve courses in close proximity to the brachial plexus. At the level of C5, it lies very close to the brachial plexus. It less than 10 to 20 millimeters. But as we travel down from the C5 or C6 level, it diverges for about 3 millimeter away from the brachial plexus. For every 1 centimeter, we descend from the C5 or C6 level. This is a video of showing the sonoanatomy of the phrenic nerve. So this is your anterior scalene muscle. This is the brachial plexus element C5 and C6, and this is the middle scalene muscle. And muscle much more on superficially is your superficial sternocleidomastoid, and this is the deep cervical fascia, and phrenic nerve lies beneath that over the surface of the anterior scalene muscle. Here you can see my probe is moved from cranial to caudal. You can see a small hypoechoic shadow moving over the anterior substance of the anterior scalene muscle. That is the phrenic nerve. As we move down, from C5 to C5 level to down, it moves away from the brachial plexus element. As we move again carefully to the C5 level, it lies very close to the C5 root. This can be seen only with the help of ultrasound. That's why with the help of an PNS or landmark technique, we don't know where your needle tip is. One more important nerve that you have to know is accessory phrenic nerve. It is present in 1/3 of the individuals. It arises primarily from the C5. It gives an independent contribution to the phrenic nerve. So local anesthetic blockade of the accessory phrenic nerve might also lead to hemidiaphragmatic paralysis. Okay. What happens when the unilateral diaphragm gets paralyzed? We all know that diaphragm is the primary muscle of inspiration. During inspiration, the diaphragm contracts. What happens is the chest cavity enlarges, thereby creating a negative pressure, reducing the pleural pressure. Thereby, it enhances the entry of air into the lungs. This is the basis of your inspiration. When there is a paralysis of a diaphragm on one side of the body, what causes that? When the pleural pressure is negative, what happens is that inspiration causes the paralyzed diaphragm to move. Along with it, it carries the abdominal contents into it. So ultimately, the lung volume is reduced on the side where it is blocked. Usually, in normal patients, they are asymptomatic with this unilateral phrenic nerve palsy. But patients with pulmonary comorbidities or pulmonary complications like bronchial asthma, COPD, or any other tumor or any tuberculosis, they are more symptomatic when there is hemidiaphragmatic palsy, because they need compensation from the other side. That is not possible with patients with pulmonary dysfunction. What happens when there is hemidiaphragmatic palsy? It decreases the FEV1 by 15 to 40%, forced vital capacity by 13 to 40%, peak expiratory flow rate by 15 to 43%. So these decrease in volumes may not be evident in a normal patient, but there will be more evident and more symptomatic in a patient with old age pulmonary or with old age with pulmonary dysfunction. They might land up in immediate hypoxia and dyspnea. Some patients might arrest immediately on table, or some patients will be more symptomatic. How can you treat these type of patients? Make them sit up, give oxygen support, and then give non-invasive ventilation. If needed, some patients might be requiring intubation and elective ventilation until the diaphragm function recovers. How can you identify whether your diaphragm is getting paralyzed or some other cause? It's very simple. Just place an ultrasound curvilinear probe on the right side of the chest in the midclavicular region, just below the subcostal region. Try to scan the liver and scan little carefully. You will see the diaphragm moving with respiration. In normal individuals or pre-block, there will be an excursion of about 3 to 5 centimeters during inspiration. In case of patients with hemidiaphragmatic palsy, there will be no excursion. Then what are the options we have left with? Then comes to the term called phrenic nerve sparing brachial plexus block. We are going away from the classical interscalene block. What are they? It could be a low volume interscalene block with just 5 ml. It could be superior or upper trunk block. It could be a supraclavicular block with only corner pocket deposition of local anesthetic. A newer block in origin, costoclavicular block. We are still in a dilemma that whether costoclavicular can be used in shoulder surgery. Yes, we are using, and papers have also come that costoclavicular block can be used for shoulder surgeries. infraclavicular block with the supplementation of suprascapular block and axillary nerve block, or suprascapular nerve and axillary nerve individually you can block as such. And of late, you can avoid depositing local anesthetic near the brachial plexus, and you can take it to the back where you can block the erector spinae plane block. Okay, let's see one by one each of the blocks. First is the low volume interscalene block. It is an zone anatomy and everything is traditionally as such of an interscalene block, but the volume we are restricting it to 5 to the maximum of 10 ml. And then with this, how can you prevent the phrenicnopalsy? You need to follow these 4 steps. The needle insertion and the target, it should be, the needle position should be extrafacial. It should be 4 mm lateral to the brachial plexus sheath. Your needle tip should be between your brachial plexus sheath and your middle scalene muscle. Go as distally as possible. Usually we give it at C6 level. You can go a bit down as C7 level. Low injectate volume, 5, not more than 10 ml. If possible, if you are a patient with pulmonary compromise, try to give a dilute local anesthetic concentration of the local anesthetic. With low volume interscalene block, the incidence of phrenicnopalsy is about 10 to 20%, at times 30%. Okay. Next is the block that is I am going to substantiate in this lecture. Everyone has to know about this block because this has changed the regional anesthesia for shoulder surgeries. It is the superior trunk block or upper trunk block. It is formed, superior trunk is formed by the ventral rami of C5 and C6. It lies between the anterior and the middle scalene muscle. It is usually formed caudal to the C7 transverse process. Why? Because all the innervation to the shoulder joint gets branched out after the superior trunk is formed. That's why this block has revolutionized for shoulder surgery. And then we have to deposit the local anesthetic before the suprascapular nerve takes off from the superior trunk. The superior trunk, as soon as it forms, it divides into 3 branches. The suprascapular nerve, posterior division of the upper trunk, and the anterior division of the upper trunk. A small mnemonic called SPA. These are the 3 branches that is given off immediately after the superior trunk is formed. So you have to deposit the local anesthetic before the suprascapular nerve takes off. Usually, 5 to 10 ml of local anesthetic will suffice for this block, and the incidence of hemidiaphragmatic palsy is about 5%. There is no block still that you can prevent the hemidiaphragmatic. With superior trunk block, we can reduce the hemidiaphragmatic palsy, incidence of hemidiaphragmatic palsy, to as low as 5%. Let me describe how to perform this block. Ergonomics is very important whenever you perform any block. The patient can be in sitting or slight lateral position. The performer should be at the head end, and the ultrasound machine should be in the opposite direction. Everything should be performed under a sterile aseptic technique, and a linear high frequency probe will suffice for this technique. The short video of how to locate the superior trunk. You can see this is the C5 root, this is the C6 root, both of the join to form the superior trunk. It lies between your anterior scalene and the middle scalene muscle. So you can see that this is the C6 coming out of the transverse foramen. C5 already there. They both join to form the superior trunk, which lies between your anterior scalene muscle and the middle scalene muscle. Next, you can see this is my C7 transverse process disappearing. That's how I differentiate a interscalene block from a superior trunk block. If you give the block before the C7, that is called an interscalene block. And if you give a block after the disappearance of C7 transverse process, then it is called an superior trunk block. This video shows the needling technique. The needle will be approached from lateral to medial. It will be coming from lateral to medial after piercing the skin subcutaneous tissue. This is the prevertebral fascia. The needle is coming on top of the middle scalene muscle. the needle pierces the prevertebral fascia. Just pierce, go to pop off. And then my needle tip is close to the brachial plexus sheath. Same way, the drug is deposited around the superior trunk. 5 ml is suffice. If you are not that okay, you can go maximum up to 10 ml, not more than 10 ml. If the volume exceeds 10 ml, then the chances of incidence of phrenic nerve palsy, percentage of phrenic nerve palsy increases. That is the only advantage with your superior trunk block. Aspirate and give in small aliquots like 1 ml or 2 ml. Make sure that the drug spreads around the whole of the branches of the superior trunk. Okay. There are various studies have come how superior trunk is superior to the interscalene block. It provides a non-inferior surgical anesthesia to the shoulder region. It reliably blocks the C5 and C6, thereby providing anesthesia to the shoulder and the proximal humerus. It has a very low incidence of phrenic nerve palsy, about 5%. Better safety profile than interscalene block, and most important thing is the low risk of injury to the long thoracic nerve and dorsal scapular nerve, which sometimes gets blocked as they lie in the substance of the middle scalene muscle, which is usually injured while performing an interscalene block. What are the complications that can come occur when we are giving a superior trunk block? Transverse cervical artery sometimes can lie between your C5 and C6 nerve root, so that can be damaged, or it could be punctured, or intravascular injections are always possible. Suprascapular injury to the suprascapular artery. Phrenic nerve palsy, 5%. If the volume increases, then the percentage increases. Local anesthetic systemic toxicity if it is injecting into the any vessel, and sometimes Horner syndrome is also witnessed. Next, costoclavicular. Yes, costoclavicular block can be given for a shoulder surgery. We usually give it for geriatric patients with pulmonary compromise. How can a costoclavicular block will suffice for a shoulder? Let's see. Costoclavicular space, it lies in the infraclavicular region. It is a medial infraclavicular space that lies between your pectoralis major subclavius anteriorly and the serratus anterior posteriorly. Costoclavicular space and supraclavicular space are contiguous anatomical spaces. They have a connection between those two. Usually with a 20 ml of local anesthetic, we don't see much volume in the supraclavicular area. But once if your volume exceeds 25 ml, you can see a part of local anesthetic in the supraclavicular area when you scan that. It acts as a retrograde channel to block the supraclavicular brachial plexus. Usually 20 to 25 ml of local anesthetic will suffice. The incidence of papers have shown that incidence of hemidiaphragmatic palsy is 0, or it can maximum to the 5%. Even you can insert a catheter and give a continuous analgesia with this block. This is a video to give a costoclavicular block. This is an axillary vein, and this is the second part of the axillary artery. These are the plexus that are arranged lateral to the artery. My needle is coming from lateral to the medial direction. Very superficially is the lateral cord, and this will be the posterior cord, and close to the artery will be your medial cord. As we are depositing the local anesthetic at the level of cords, your suprascapular nerve, axillary nerve, musculocutaneous nerve, subscapular nerve, all these nerves are blocked with this technique. You can see I just pierced the septa that connects the medial and the posterior cords. Local anesthetics is evenly distributed around each and every cord. Medial cord moves a little down. So these are the two primary blocks that are preferred nowadays for shoulder surgery. What are the other blocks that can be done? It could be a suprascapular block. Either it can be blocked in an anterior approach or in the posterior approach. Anteriorly, you block at the supraclavicular fossa, where it branches out from your brachial plexus as a group. It is the lateralmost part of your brachial plexus in the supraclavicular region, just beneath the omohyoid muscle. 5 to 10 ml of local anesthetic will suffice for blocking this nerve. Incidence of hemidiaphragmatic palsy is 10 to 20%. Next is, we can block the suprascapular nerve posteriorly over the spine of scapula below the supraspinatus muscle. This is a small video showing how to trace the suprascapular nerve, placing the probe over the spine of the scapula. You can see a small pulsating structure. That is your suprascapular artery that lies within the transversscapular ligament, and the suprascapular nerve lies adjacent to it. Just depositing local anesthetic of 3 to 5 ml adjacent to the artery will suffice to block this nerve. Next is an axillary nerve block. This can be done at the posterior part of your upper arm over the humerus. Okay, here with an ultrasound, you can see the superficially deltoid muscle and teres major just above the humerus. Here also a vascular marker, a circumflex humeral artery, lies close to the axillary nerve. You can see the pulsations. Once you identify the artery, you can bring in the needle in plane from capillate to caudal, and then deposit of about 5 to 10 ml of local anesthetic. That will be sufficient to block this axillary nerve. These two blocks, suprascapular nerve block and axillary nerve block, are insufficient for a sole anesthetic block. They are usually combined with the GA for arthroscopic surgeries. These two blocks lead to suboptimal pain control and incomplete analgesia technique. You can't do with the pure anesthetic technique. With these two blocks alone, you can't do a case. Either you have to combine with the general anesthesia. That's why these blocks are not fully useful. Next is an erector spinae plane block. Of late, many papers have come that you can skip the brachial plexus anteriorly and then go back to the back, where you can block the ventral and dorsal rami with the help of erector spinae plane block, where you can put in the needle in plane from cranial to caudal, pierce the muscles, 3 muscles, trapezius, rhomboids, and erector spinae, and hit the transverse process. And main aim is to lift the erector spinae muscle above the transverse process. Thereby, it's a facial plane block. The local anesthetic splits in the facial plane and then blocks the dorsal and the ventral rami of the cervical nerve roots, cervical and T1, like C6, C7, C8, and T1, thereby giving analgesia to shoulder surgeries. This also, usually it is combined with the general anesthesia or a TIVA, not as a sole anesthetic. It is used to combine with the general anesthesia, and it has come with good positive results in preventing hemidiaphragmatic palsy in high-risk geriatric patients when combined with the general anesthesia. Next, just a summation of all the blocks. Interscalene usually blocks at the level of roots. It blocks all the nerves that supplies the shoulder joint, but only caveat is that it gives about 100% of phrenic nerve palsy. That is the very unwanted complication that we are about to. Next is the supraclavicular nerve block. It blocks the trunks and divisions of the brachial plexus, but it also has high incidence of phrenic nerve palsy. Next is the block of our choice. It's an upper trunk block. It blocks all the nerves that supplies the shoulders with least amount of phrenic nerve palsy. It gives non-inferior pain control when compared to interscalene block. Next is infraclavicular block. It can also be done with the supplement of suprascapular nerve, because at the level of lateral infraclavicular region, the suprascapular nerve branches out and it doesn't have a connection with the supraclavicular region. So if at all you are getting a infraclavicular nerve, we need to make sure that suprascapular and the axillary nerve is blocked. Next is the suprascapular nerve that can be blocked either anteriorly or posteriorly. Then individual axillary nerve block that can be done at the posterior of the humerus. And next comes your costoclavicular block. It blocks the brachial plexus at the level of quads. Almost it also blocks all the nerves that supplies the shoulder region, and it has the least incidence of hemidiaphragmatic palsy. Still, there are RCTs. Still, we need fully controlled RCTs, like big associations and eras for guidelines, how much of volume for costoclavicular, what are the incidents, what are the complication, and all these things. Future studies are also necessary. Even for erector spinae muscles, we need further RCTs and guidelines for erector spinae for shoulder surgeries. On top of it, the shoulder also receives some dermatomal innervation that is not blocked with the brachial plexus block. What are they? They are the intercostobrachial nerve, supraclavicular nerves. So we always need to block these sensory nerves, supraclavicular nerve and an intercostobrachial nerve. Intercostobrachial nerve, it depends upon where the incision is. If the incision is deltopectoral groove, in the deltopectoral groove, we need to give an intercostobrachial. If the incision is much more lateral and posterior, no need to give an intercostobrachial nerve. But supraclavicular nerves, you should always you have to give a local anesthetic infiltration over the neck to block the supraclavicular nerve, because the nape of the shoulder is supplied by your supraclavicular region. Unless and until you block this nerve, the patient will have inadequate analgesia and he will have all complications like he will shout out of pain or hypertension, tachycardia, and everything. How to block the supraclavicular nerve? Supraclavicular nerve is the inferior branch of superficial cervical plexus. It courses underneath the sternocleidomastoid muscle over the middle scalene muscle. It consists of three main branches: medial, intermediate, and lateral. It provides sensory innervation to the skin and the apex of the shoulder region. Here you can see the apex of the shoulder region is mainly supplied by your supraclavicular nerve. How can you block this? You can just give an infiltration at the midpoint of the sternocleidomastoid muscle, or with the help of an ultrasound, you can combine with a superior trunk block with a single needle entry. Initially, you can block the superior trunk, and you can just withdraw the needle and place the needle tip between your sternocleidomastoid muscle and your middle scalene muscle, where you can deposit the local anesthetic of about 10 mils. That will suffice to block the supraclavicular nerve. You can just see that my needle is beneath the sternocleidomastoid muscle. After deposition of the local anesthetic, you can see the nerve settlement. By this way, with a single puncture, you can do both superior trunk block and a supraclavicular nerve. Next is the intercostobrachial nerve. It lies more anteriorly, anteromedially to the upper arm. You can just infiltrate over the deltopectoral groove. Just a thin infiltration of about 10 mils of local anesthetic will do, or you can do it with an ultrasound guided in the axillary region. It lies very superficially. So unless and until you block these two dermatomal nerves, your block to the shoulder is not complete. You will land up, the patient will land up in pain or inadequate analgesia and anesthesia to the patient. I thank once again for the office bearers of the SAMS for giving me this opportunity. I hope I did my job. Thank you very much. Thank you, moderator ma'am. Any questions, sir?
Charutta madam, you're going to say something?
I request Charutta madam. Yes, sir.
Yeah. So thank you, Dr. Senthil Kumar, because it has been a very informative lecture. Actually, the people who are practicing high volume centers for shoulder surgeries, where you are conducting the surgeries entirely under regional, it's a different issue altogether. We had been actually combining various blocks, but always with GA. So purely under regional, I would not be able to really have a discussion much on it. But I will request those enthusiasts who are really practicing it to go ahead and ask questions to Dr. Senthil Kumar.
Yeah, Charutta ma'am, I had some few questions.
Yeah, sure. Go ahead.
Yeah. Sir, you said there is 100% phrenic nerve palsy if you give PNS guided.
Yes,
but
yes,
yeah, so like many of our private practitioners, especially in Maharashtra, we are still using PNS guided. And once I had when I was simulating the interscalene with PNS,
yes,
where I could see the diaphragm contraction. So is it possible that we adjust the PNS at a higher range and then approach to see whether we are near the phrenic nerve to avoid that palsy?
No, it shows that you are too cephalid and you are directly stimulating the C4 nerve root.
Okay,
You have to
when I got the
reposition the
diaphragm
needle
contraction.
little caudally.
Okay, but in clinical practice, we don't see that frequency of phrenic nerve. So is it just the paresis which is occurring because of the drug,
No, ma'am, as I said before,
not the palsy actually?
no, as I said before, it will not be evident with normal patients, ma'am. It will be more evident with patients with the pulmonary dysfunction. Why? Because in normal patients, the opposite lung compensates for all the deficiency. And then you will not be evident unless until you put a probe over the costal region and see for the diaphragmatic movements. Next time when you get a chance, you put a probe over the costal region and the mid-clavicular region on the right side and see almost all of your interscalene patients, almost 80 to 90% of the patients, you will not be getting this excursion now, about 3 to 5%. But the patient will be asymptomatic. But it is evident in ultrasound.
Okay, sure. Sir, you explained about the superior trunk block, but that ultrasound guided, whatever, like since 2015 or 16, we are giving ultrasound guided. So we give that same superior trunk block is a part of interscalene, isn't it? Like, why special mention about it?
Because as I said, just a minute. So this is the explanation for that, ma'am. Because the phrenic nerve lies close to the C5. When you come down, the phrenic nerve goes away from your brachial plexus. So thereby decreasing the incidence of your phrenic nerve palsy. When you deposit about 10 ml in interscalene block, the chances of the drug ascending up and blocking the C4 nerve root is more than when you give a 10 ml of drug after the C7 level in superior trunk block. That is the main mechanism behind it.
Okay, understood. So it has to be a little at the C7 level.
See, below the C7 level. That's why I put it in the ultrasound machine. That usually they say before the supraclavicular nerve branches out, but it is very hard to find out. But as we have a bony landmark, it is easy to visualize in your ultrasound. So this is your C7. Once your C7 transverse process disappears, then it is the superior trunk block.
Okay. Sir, is it possible that phrenic nerve palsy can manifest after 2 hours? There are few case reports where the patient has some breathlessness in the recovery area, and when you scan the lung, you can see the diaphragmatic palsy.
Yes, it can, ma'am. It can. Why main mechanism is that one of the mechanisms I have told before.
Okay, sir. I think
volume might ascend up and block your C3, C4, and C5. Initially, the patient may be comfortable, but as the surgery proceeds, the volume might ascend up.
So that can happen after 2 hours.
Yeah,
like there are few cases.
But very rare, but it can also happen.
Okay, sir.
Dr. Senthil, I want to ask you a question.
Yes, sir.
You said that only 5 ml or maybe 10 ml drug is to be deposited.
Yes,
practically, is it adequate drug for that much?
Yes, it is adequate. We are doing like that.
Okay.
For high risk proximal humerus surgeries with geriatric with pulmonary dysfunction, maximum of 10 ml we give that.
And in which patient you are extremely careful about blocking phrenic nerve? One is you said poor lung function, other is geriatric and
obese patients with short necks. They have high incidence of drug ascending proximally and blocking the nerve roots of C3, C4.
Okay.
Obese, short neck, mostly women.
Okay.
And how much percentage of drug you are using?
For pure anesthesia, we use 0.5% bupivacaine or 0.75% ropivacaine. If you are combining with general anesthesia, we'll be doing it with 0.2% ropivacaine or 0.25% bupivacaine.
And any additives that you are using?
Dexamethasone.
Okay.
4 or 8 milligrams.
So you use a combination of drug or only one single drug?
it depends upon the consultant, depends upon the whom you are giving. Personally, I use a single drug, but other consultants, they use mix of drug or lignocaine and bupivacaine and everything.
Okay. And we routinely give USG guided blocks. So
Okay.
either scalene or subclavian perivascular. So I wanted to know that where do you keep the orientation marker? You keep it medially only, or you prefer to keep it laterally? Everybody does it different way, but I just wanted to know what is better.
There is no strict prototype or protocol or
Yes,
anything like that.
yes,
It's
but
how you are oriented in your brain. It's how you visualize the thing. That's all. You can keep it either medially, laterally. That doesn't make. It's how you are oriented. How you visualize the structure or anatomy.
okay.
That's more
But
important. There is no strict
visualizing
guidelines
the
that.
needle, does it get easier when you keep the eye laterally
No,
visible?
that it depends upon individual preference. When you ask me, I keep the marker medially. Why? Because it's easy for me to
Correct.
orient that the needle comes from lateral to medial. In the
Yes,
screen also, it comes from lateral to medial.
yes. Okay.
It's individual preference, ma'am. There is no strict prototype or like you have to do like that, like that. It's not. It's how your brain is oriented and how you visualize over the screen and how you can comprehend, which is anterior, posterior, medial, lateral, and it's how you are comfortable with.
Yes, I'm more comfortable with the marker placed medially, so that's why. And many people like it placed laterally. So I wanted to know if the visualization is easier with the lateral pointer. Okay.
Each one of us
So
have a
there is,
different style.
yeah,
Thank you.
thank you, sir. So there is one more question. Incidence of recurrent laryngeal nerve palsy after supraclavicular block.
Very, very rare, ma'am. Very, very rare. Very, very rare. Until you go into that vagal sheath and then close to the vagal sheath and all those things. Very, very rare. Unless until you go too medially or too anteromedially.
Okay. Sir, you had mentioned that usually with general anesthesia, the MAP decreases.
Yes,
But
yes,
if we
yes.
maintain MAP, can we give general anesthesia? Nowadays,
yes.
we don't give.
Yes,
But,
yes, we can give. We can. In our centers, all trauma cases are done under regional anesthesia, but a scopy, the surgeon is not comfortable with regional anesthesia. So we give a GA with a block. So you have to go with the surgeon. You can't say I'll be giving only a block. Surgeon is more comfortable with the GA. So we give. But the chances of hypotension is more with the GA when compared with the regional anesthesia. Because all those reflexes, baroreceptor reflexes, everything are attenuated with the general anesthesia. And then,
so we have to maintain the MAP. Sorry. Yeah, what you were saying, sir?
Yeah, that's what I was about to. MEP minimum of 65 millimeters of mercury should be maintained because the brain autoregulation is from 50 to 150. So the height of the brain from the heart level is about 20 centimeters when you make the patient sit down. So ultimately, your map reduces from what you see in the monitor, the brain map. So that's why they say with the near infrared spectrum analysis and studies, they found out that 80% of the patients who are on GA and made to sit up, whatever procedure may be, they land up in decrease in cerebral perfusion pressure and cerebral desaturation. 80%. That gets worsened. That gets worsened when the patient is in chronic diabetic with autonomic neuropathy, when the patient with atherosclerotic disease somewhere else. Any CAD, he may have a plaque in the carotids also. So he is prone for all those cerebral circulations, dysregulation. And then patients who are on antihypertensive, morning dose of losartan, immediately after making the patient sit, it will drop to 70-40. With a patient more prone for stroke, he will develop some neurological complications immediately before the next BP comes. So they say you can start phenylephrine infusion continuously.
Oh,
or given a bolus of phenylephrine or ephedrine before you make the patient sit up, or you can gradually make the patient sit up. For every 10 degree, you can pause for about 30 seconds, and then gradually you can make the patient sit up.
Okay, so there is one more question. How much time patients are comfortable in beach chair in only blocks, and what sedation and airway protection under heavy draping for shoulder surgery?
It's all individual patient oriented, ma'am. If the patient is completely fine, if he's pain free, he is fine, no sedation is required. If the patient is little apprehensive, you can give a minimal dose of opioids, and you can give an dexmedetomidine infusion where there is no airway or pulmonary compromise. There is no CO2 retention, all those reflexes are maintained. So, in my opinion, dexmedetomidine is the best sedation where we can give. 3 hours, we have done cases for 3-4 hours also, the patient comfortably and dexmedetomidine.
Okay, great.
Because
And
the
any-
dexmedetomidine will not bring down your attenuative airway reflexes or hypoxic drive, and everything is preserved with the dexmedetomidine, not like unlike other hypnotics or even with the propofol infusion.
Yeah, that was really great, sir.
I just wanted to share that I've come across at least 2 to 3 patients who had post-op delirium and slight confusion for some time.
Yes, ma'am. That is the what is it? Most common neurological complication that come across, and the most what is milder form of neurological complication you can see. That could be one of the drop in hypotension or a prolonged drop in hypotension that is unnoticed or uncorrected.
Yeah, sorry. So the patients had some confusion for some time, and then later on in PACU they recovered and got better. But when they woke up on the operation theater, like they were completely disoriented. They could not even remember where they were from. So though the map, I'm extremely careful about the map. But I think in elderly and patients with atherosclerotic disease, it's common, and
Yes,
I've seen
absolutely, yes.
things like that.
Yes. Sometimes the surgeon might ask you to reduce the systolic blood pressure, but you can reduce the systolic blood pressure, but with the help of phenylephrine, a small dose of phenylephrine, you can increase the diastolic pressure so that the map is maintained.
Yes.
You can keep the systole at 90, and then with small doses of phenylephrine, you can increase the diastolic pressure and the venous return. And while positioning, you have to follow the knee chest level. The knee should be at the chest level so that the venous return is enhanced. You can keep more pillows. You can stack pillows beneath your legs so that the knee comes at the level of the heart.
Yes. We also put on Flotron, so that's also not a
that's also one of the preventive
Yes.
measures that can be used.
But I've seen it with prolonged surgeries, like if the surgeries lasted for 4 or 5 hours in elderly patients, then it's sometimes. So that's why shoulder surgeries, I always wait back till the patient is shifted to the PACU. I ask some questions, and only when I'm comfortable, I leave that patient.
Absolutely. That is the milder form of cerebral neurological complication, what you have mentioned. You can just reassure, you can wait for 12 hours. If you are little skeptical, immediately you can move into MRI suite and take an MRI, not a CT. MRI gives you faster diagnosis of a stroke than a CT.
Yeah, but with stroke, there will also be some other neurological manifestation.
Not necessarily, ma'am.
Not necessary.
Not necessarily. Each one will
Okay.
come out with different signs and symptoms.
Okay. So there is a question: which PNS responds to accept to superior trunk block?
Biceps, deltoid, triceps. But with PNS, it's very difficult to locate. You can't tell. You can pinpoint that it's superior trunk. Only with ultrasound you can pinpoint that you are the superior trunk.
So maybe the private practitioner is looking retrospectively that if I get this response, then I will deposit the drug there. It can be that way.
With PNS, it's very difficult to tell, ma'am, where the needle tip is. Only thing, you avoid a diaphragm contraction. Avoid injecting local anesthetic when you get a diaphragmatic contractions. Best response will be the biceps, triceps, deltoid, and pectoralis.
Okay, sir. Okay.
Sir, previously we were using that soda bicarb and Hyalase. Nowadays, are you using any additives to the local anesthetic? Like Hyalase and soda bicarb to increase the
I think that is,
pH?
those are not recommended nowadays. dexamethasone will be ideal for prolonging the duration of analgesia or anesthesia.
Yeah. Okay, thank you.
Sir,
Thank you.
thank you. So there was a question whether two additives can be added. Like sometimes I might be adding dexamethasone and clonidine. So is it right combination or what, sir?
With this, for shoulder surgeries, I will not add, ma'am, because if at all patient develops semi-diaphragmatic palsy, then it will be worse come scenario, because the duration of it will be prolonged.
For other blocks, supraclavicular
Other
or
blocks, we usually give a single additive, ma'am. Either mostly dexamethasone, if at all only dexmedetomidine, not both.
oh, okay, sir. Thank you.
And I want to tell, if at all, if you get a phrenic nerve palsy, what to do? There are some studies and there are some papers. Injecting saline close to the surface of the anterior scalene muscle or into the interscalene groove itself. About 20 to 30 ml of normal saline. That they say that it will dilute the local anesthetic concentration or it will wash away the local anesthetic concentration for faster recovery of your diaphragm. But it's
Okay,
not
but
proven. It's just a case reports, not an RCT or anything.
will it not ascend the drug? Will it not ascend the block?
Yeah, that is a possibility of that also. But already the phrenic nerve is blocked, so it doesn't. It will ultimately dilute the local anesthetic concentration.
So what about buprenorphine in the blocks? And also, actually, I wanted to ask buprenorphine also in abdominal blocks. And someone has also asked for shoulder block.
We don't. We don't use any buprenorphine in Ganga, just for sedation only, not in the blocks. So I don't have experience of using buprenorphine.
Okay, not even the tab blocks or this.
No, usually dexamethasone or fetal dexmedetomidine, not anything else.
And fentanyl, sir?
No.
No.
Is there
What
any?
about
Yes,
Hello?
ma'am.
One question is there, can we add highlights to the local anesthetic drug?
No, sir. Previously, they were using all those things, but nowadays, all associations, they don't recommend, sir. Guidelines don't recommend highlights, soda bicar, everything.
So, like when you're giving the block, that time, is it necessary to lift up all the, say, trunks and you give the block only at one point or you go below the trunk and above the cords?
And
So,
ideally, as I said before, place your needle tip between the middle scalene muscle and the brachial plexus sheath.
huh.
Don't go anteriorly. If you go anteriorly, the chances of phrenic nerve palsy is more. If
Yes.
you go close to C5 also, there is the phrenic nerve palsy is more.
So just at one point only you give the
Just
drug.
1 point injection is more than sufficient.
Okay, you don't try to go above the cord.
No. It's better to avoid those maneuvers.
Okay. And
So
Bala sir talked about when your needle is very close to the fascicles, that time there is prolongation of the block, and postoperatively you get a call saying that the block has lasted for many hours.
Yes,
So like when we are adding dexamethasone, so that time we think that the prolonged action is because of dexamethasone. So like how to differentiate between the two?
No, you can come down on the concentration, ma'am. Usually, we also get this type of issues with our surgeons when you give a block in the popliteal sciatic, where with the dexamethasone, the patient will not move their toes for about 24 hours to 36 hours. That's also has happened. Even in diabetic neuropathy patient, it worse come worse, it will be up to 2 or 3 days because already half of their nerves are gone. So what of late what we have done is we have avoided dexamethasone in popliteal sciatic block, and then we are giving only 0.1 ropivacaine or 0.125 ropivacaine plain.
Okay. But
That
what
will-
about the shoulder blocks, sir? Shoulder
Sorry, sir?
blocks, how much of dexa are you adding?
4 or 8 milligram.
4
Either
or 8.
eight.
Okay. But there's no way to differentiate whether you are close to the fascicle while giving the block.
No,
So
no,
that's
that's what
why
that we can't
it is
differentiate
not
until
slow
you
down.
have good resolution of the high-end ultrasound machines. Then only we can, while giving injection, your needle tip position, you can identify whether you are in the subparaneural or in the above the paraneurium. One thing is that the onset of action will be quicker with subparaneural injections.
Okay.
Onset of action
And
is quicker with subparaneural.
Okay.
and
Sometimes
we
in obese
also use
patients, I'm sorry. Sometimes in obese patients, the anatomy is not very clear. So when the anatomy is not very clear, so that time do you do anything differently so that the anatomy becomes clearer?
No, you can always go with the dual guidance technique, or you can just change the settings in your ultrasound machine. Whenever you see on top left, just beneath the screen, you have three options like resolution, general, and penetration mode. I think tomorrow you can just go and have look at it. If you switch on to the penetration mode, your ultrasound probe will give you the lowest frequency with that bandwidth. For example, in a high frequency linear probe, you have a bandwidth of about 8 to 13 or 7 to 14 or 8 to 10. When you select that penetration mode, the ultrasound rays emitted from your ultrasound probe will be the lowest frequency, like 8 to 10. So that it gives it the ultrasound rays that can travel much more deeper, and then it will give better resolution when compared to the resolution mode, where the frequency bandwidth frequency emitted will be around 11 to 13 megahertz.
Sir, what I meant was anything you do differently while positioning the patient. Supposing very obese patient with short neck. You're not seeing the anatomy well. So do you give the
you can
position
extend the neck if necessary, or you can put the patient in lateral position or sit up. You can just give a pillow beneath your scapula so that your neck gets extended.
Okay.
Another thing is the mnemonic of
sometimes
PART.
we placed a saline bottle covered with a drape under the shoulder.
Sorry, ma'am, I didn't get you.
Yeah, like how we put IJV, so that way.
Yeah, the same. And then some ultrasound probe, you can, the PART maneuver is that pressure, alignment, rotation, and tilt.
Okay.
If you make sure all these four maneuvers are correct, then obviously you'll get a better image. Whatever type
Sometimes when you want to do the procedure only under block, like in high-risk patients and all, they're already having a lot of pain, fracture and all. So those patients, it gets little difficult if the patient is obese. But otherwise, after GA, when you are giving the block, then you can do things.
You can just give 40 mg of fentanyl, ma'am. Not going to compromise on their respiration or anything. They'll be comfortable. Then you can give the block peacefully.
Yes. Thank you.
So the last question. Sorry, Balaji sir.
Yes, madam. Last question. I think we should wind up now.
Yeah. How long does it take to recover from hemidiaphragmatic paralysis?
It depends upon the volume and the concentration what you give, and it depends upon the individual patient. We have come across a young lady, 35, 40 years old, about 4, 5 years back, came for a shaft of humerus. We gave an interscalene block. Immediately, she went into respiratory distress. Retrograde, when we tried to ask history, she told that she's a known asthmatic. So immediately we put a Bain circuit and we ventilated. We helped her. We just sedated her with the midazolam so that the anxiety can be relieved. And then we made a sit-up, and then with an NIV support of about 2 to 3 hours, she became all right. And then we observed until evening, and then she was fine, and then we sent her to the room. The procedure was to be postponed to the next day, and the next day we did it with the costoclavicular block alone.
One more complication I had seen in case of shoulder surgeries under interscalene block. I've given general anesthesia with interscalene block for one patient, and the surgery wait for 5 to 6 hours. The surgical complication was that the irrigation fluid percolated and migrated through the subcutaneous tissue and the spaces, and huge edema occurred right all around the chest and larynx, oropharynx and laryngopharynx, all over the edema was there. The patient was fully awake, but I could not extubate the patient because airway from inside. It was narrowed, it was edematous, and patient could not take a breath from that airway. When I tried for extubation, the patient's saturation was going down. Again, I have used laryngeal mask, LME, and asked ENT surgeon and done a tracheostomy. I put a patient on a spontaneous ventilation for 1 day in ICU, and in next 24 hours, when the edema was reduced, I closed the tracheostomy and discharged the patient from ICU to the recovery. That was one of the dreaded complications I have seen in the patient of shoulder surgery.
Better to retain the tube for a while, sir. If the surgery prolongs for more than 4 hours, better to retain the tube, relatively ventilate the patient for about 3 hours, make them sit up until comfortable.
That was the idea. That was the idea in my mind, but patient was not tolerating the tube at all. The patient was wide awake, and everybody was saying not to put on a ventilator and paralyze the patient again and sedate. So better idea, I shifted to tracheostomy and kept the patient on a spontaneous ventilation and wide awake. Okay, with this, we should move on. And a very excellent lecture by great academician, Dr. Bala Venkat sir from Ganga Hospital. I'm thankful to Dr. Bala Venkat sir on behalf of SAM. I'm also thankful to Dr. B. Senthil Kumar for informative lecture. He's also from Ganga Hospital and delivered a very informative lecture on the regional anesthesia for shoulder surgery. I'm very much thankful to Dr. Charuta Gadkari madam to accept our request to be a moderator of this session. We had a big question in front of us to whom we should appoint as a moderator, and the name came into our mind is Dr. Charuta Gadkari madam, and fortunately she was PR of Dr. Bala Venkat sir. We are also thankful to Dr. Avinash Professor, Dr. Vikas Karni, Dr. Shilpa Tivaskar madam, who helped us in the webinar as usual all the time, who are backbone of our SAM. We are thankful to Dr. Balaji Asegawkar, our president sir of SAM, who has given best team as a recent advances in anesthesia for SAM. Lastly, we are thankful to all the respected seniors, colleagues, and juniors who have attended this webinar. Thank you very much.
Thank you so much.
Thank you very much.
Thank you, sir. Thank you, everybody. Thank you.
Thank you, everyone.